Hello, this is Al Ali. I'm the Chief Editor of Plastic Surgery Education Network, and we're here at Plastic Surgery 2011.
Plastic Surgery 2011, I think, was a really good meeting from a lot of perspectives. I sensed a real excitement, some vibrancy related to both the reconstructive and aesthetic surgery presentations.
We just finished a panel on current concepts in fat grafting of the breast, and we talked about fat grafting in the purely cosmetic patient, the reconstruction patient, and then the in-between patient, and then even breast conservation patients who've been radiated.
There are very different situations after lumpectomy plus irradiation. We found cases in which you can have even an ulcer, and in that case the strategy is different because you have to start with a small amount of fat just to provoke a regeneration of the tissue. And then when the tissue is soft, you can go with the purpose to achieve a new shape and a new volume.
We had a panel this morning on the safety of liposuction in conjunction with abdominoplasty, focusing on the liposuction of the abdominal flap of the front at the same time. And I spoke about the high lateral tension abdominoplasty, and my emphasis is that most rejuvenation of the abdominal area is really an excisional procedure. It has more to do with the removal of skin. And the more skin we remove, the better we tighten and improve the thighs, almost getting a body lift. And that we can get enough tension and enough flattening up here that, in my opinion, we don't need to do liposuction here, even though it safely can be done at the same time as an abdominoplasty.
In the panel that I did on consecutive mastopexy augmentations, one of the questions we asked at the beginning was how many people are using vertical techniques versus inverted T versus circumarelar, and I was actually a little surprised at how many people were using vertical. I think that's actually easier for surgeons to learn how to use vertical in mastopexies and mastopexy augmentations, and it takes them a little longer to start using them for some of their breast reductions. So I was a bit surprised that that many people use vertical.
The panel on the management of pain talks about the application of surgery for migraine headaches, which is certainly something that has not caught on in all medical centers, and that's certainly an area to pay attention to.
Initially came from a patient, a surgeon's wife, who came for a follow-up after having had forehead lift. She stated, "Not only am I happy the way I look, I haven't had migraine headaches for a long time." We have been able to demonstrate that it really works and it lasts.
The aesthetic refinements and using aesthetic principles in secondary cleft lip and palate surgery. Clearly, I think that everybody understands that the primary repair is your best shot at getting a great result and setting the stage for the prolonged treatment of these kids anyway. But it's really important to be able to follow up with sound secondary surgery, which virtually all of these kids are going to have.
Innovative techniques in head and neck reconstruction. I have a feeling that we're going to make some significant advances in using the computer-assisted design approaches, particularly as was discussed today. It's been a dramatic improvement in our ability to be accurate.
I spoke about face transplants. The team I lead is the leader in face transplant. We've done 7 out of the 18 around the world. And I showed here how we do it, how we're evolving, and the long-term results. And it's not yet standard of care, but I hope in a few years, not a few months, but a few years, it's going to be standard of care from very selected patients.
I presented a synopsis of stem cell regulations and pitfalls, and in doing so, really covered some of the relevant issues that plastic surgeons need to know about when dealing with stem cells. The real critical issues when we look at stem cell therapies and plastic surgery is safety and efficacy. And there are certainly many therapies that are being marketed, especially for aesthetic purposes, where efficacy has not been shown and where safety may be in question as well.
Well, there are a number of things that some of these regenerative medicine and stem cell techniques, and through collaborations with Peter Rubin and other universities, have allowed us to expand upon a lot of the traditional reconstructive measures such as microsurgery techniques, local flap techniques, skin grafting, and various other dermal substitutes in order to expand and improve upon the current traumas and ultimately the reconstructive efforts for our wounded warriors.
I think Joe Murray once said it very well. There are the 4 R's in surgery. I think it was recognition, resection, reconstruction, and now it's going to be replacement or actually making the parts that we sort of borrowed and sort of They'll be making it in a test tube and putting it back in. It's going to be an exciting time.
This is a scientific meeting. There's a difference between a commercial meeting and a scientific meeting. In a scientific meeting, if I gave you one idea and you give me one idea, we both have two ideas. In a commercial meeting, if I gave you $1 and you give me $1, we still have $1. That's why I come and I share what I know, because I've learned from others and they learn from me. That's the way medicine progresses.